changed. And then now you have this kind of posture where everything is short here, long there, an imbalance has occurred. Now you have pain. So if I adjust this patient, I'll get him out of pain, but do we need to fix the muscle? Yes, we do. So rehab, repair, and exercise is very important. Fractures. Fractures usually happen in the spine because either they've got into an accident or it's got fragile bones because of osteopenia or density loss or whatever it is in the bone. And the person can just go, choo, sneeze and break that. And guess what? Pressure on the nerve, again, lower back pain. So I keep saying fat, fat, fat. It's one of my favorite words. Obesity is right there on the list, okay? Obesity, having too much body fat. It's not the same thing as being overweight like myself. I'm not obese, I'm just overweight, okay? Which means weighing too much because you have too much muscle. And if you'd like, I can show you muscles, but that's okay. Bone, muscle, water, and having too much fat all will qualify under that same segment of being obese, okay? Next slide for me, please. Less common causes would be spondylolisthesis, wait a minute. Ankylosing spondylitis, which is a form of arthritis that usually happens in older, not in older age, but you'll see a guy, here I'm going to show you guys a trick. You see a guy walking with their head down like this and kind of like not moving their hips right there? Ankylosing spondylitis. Form of arthritis, inflammatory, joint movement is lost. And you guys have to understand that what we do with these spinal manipulations is we adjust to keep proper movement at every segment. Living things move, dead things don't move. So the more you keep moving, the more you are living. So we'll come back to death and life. If you believe in life, you believe in death, guys, okay? Bacterial infection is another one. All those other things we don't really need to go into. Spinal tumors. I actually had recently a case. Dr. Christie saw that patient. Low back pain, I get a phone call. Patient has low back pain. She's complaining. And all of a sudden I take a look at her. All the tests that I did do not say she has a low back pain because her low back is hurt. She has pain because something in the bowels are not working properly. So right away, remember, refer. We can help each other out here. Refer the patient over to Dr. Christie. Dr. Christie takes a look at her. Sure enough, she's got gut problems going on. Okay? So as a diagnostician, we need to understand it's okay to sometimes say to the patient, we can't help you. All right? Now, when we talked a little bit about the, you can go next. When we talked a little bit about the back pain and obesity and all that other stuff, hips, knees, I actually left the feet out for a reason because Dr. Control is actually going to do a little speech maybe later about the feet, and he'll tell us how everything is connected. Your head, your shoulders, your hips, your knees, your feet. So if your feet are not aligned properly and you're not walking right, you're flat-footed or high-arched and so on, you start walking a little more in, a little more out, then you put more pressure on the knees, more pressure on the hips, goes up to the, it's all a kinetic chain. If you have low back pain and you don't fix that, it moves up to the neck. So once you understand all of that, you'll understand why when we adjust a patient, we adjust the entire spine versus just a segmental adjustment, okay? Any questions so far? Or I'm just talking a little too fast, giving a little too much information? Okay. All right, very good. Now, connection to back pain with the obesity. Now, we understand that obese people, we have impaired blood circulation, we have heart disease, we have diabetes, high blood pressure, colon cancer, and all of these are contributing factors. However, it's true that being overweight or obese can significantly contribute to the symptoms associated with osteoporosis because too much bone loading, too much weight, okay? Osteoarthritis, which is arthritis of the bones. Rheumatoid arthritis, a form of inflammatory arthritis. Degenerative disc disease, basically what happens is the disc that actually is in between every single bone has now become somehow dehydrated, which is almost, I want to say 88 to 90% of water-filled tissue is now dehydrated, so the bones start to approximate, causing a bone-on-bone rubbing, and that's where we have the degenerative disc disease. Spinal stenosis, usually seen in older patients. Spondylolisthesis, which is also seen in overweight patients because of that pelvic tilt. I want you to go ahead and skip through. Dr. Christie's looking at the time. This is something I want to show you as far as a side picture of the spine say, this is the sacrum, the end of the low back, and those two low back points right there. Normally what you do is when you take a look at this picture, you see that line going through on top, and then what you have to do is draw a straight line to see that angle. That angle is actually a perfect angle versus the angle that you look up top. You're drawing that line and you can see that it's a bigger angle. That angle actually states that there's a lot more pelvic torque, which creates more strain on different body parts. And here you have hardly any curvature, and you have a straightening of the spine, kind of like a military spine, a military neck, a military spine, basically, because they're always told to hold straight posture. But anyways, those are 3 different graphs I wanted to show you so you can understand anatomy-wise when you're looking at a picture. Next time when you see somebody walking in front of you in the supermarket or the mall, just take a look at their posture and see what you see, because that's what I do. But that's what I was trained to do. So start looking and see if you can come up with some, oh, they got scoliosis. Oh, they got a high shoulder, a high hip. You know what? Here, I got a chiropractor. Here you go. Here's a card. Why don't you come down and have her see it? Okay, so just things like that. Anything helps, guys, okay? All right, next slide. I think that should be coming into more obesity slides. I just went crazy on this obese stuff. Next. All right, when you look at certain groups, here I was just trying to put a study together, and it said something about, you have 3 groups. You have one that's the obese group, which is the O group. You have another group, which is obese with low back pain, so we'll call it a chronic low back pain. And we'll have one healthy group without the low back pain. The hypothesis here was that the obesity modifies spinal posture and function favoring the onset of lower back pain. Okay, so basically if you're obese, you're going to have low back pain, which is going to turn into chronic low back pain because you're not going to fix yourself. You're not going to bring the weight down. And I like the fact that you're thinking to sit with a better posture there. Next, so all these different factors make a difference, okay? Biomechanical differences in the spine and the mobility between the healthy group and the obese group, and more pronounced differences were found between the obese and the chronically obese with the low back pain. So I don't want to go more into that, but you can see that mostly the joint that actually takes the bend the most when you actually do a flexion will be at the L4, L5, L5S1. And 9 out of 10, maybe 10 out of 10, patient will walk in, I'll go straight to that site. 4-5, 5-1, the last 2 movable joints in the spine, and that's where you'll have the problem. And this is where the effect is happening with the obese patients with the weight being increased on there, okay? Next. And the thoracic range of motion was also significantly dropped because as a fat person, you're losing segmental movement. What happens is as you start bending, you kind of lose individual movement in every single segment. You just move right at the waist. It's important that when you're moving, the entire spine moves together and certain percentage moves at every single angle. I didn't want to bore you to death with all the little systemic like numbers and percentages, but I see everybody's already bored. I think it's the sugar level coming right down. We having dessert soon? Next, okay, treatment. What we're going to do with treatment here is we're going to adjust the patients, always adjust the patients. We're going to strengthen them. We have a lot of exercise balls. You guys have seen it. We've got TheraBands. We've got massage. I've got my massage therapist there right there now. Every day, he's not there every day. He's there Tuesday and Wednesdays, full day, okay? He's got a massage chair in the office. If you guys find someone who's, oh, you know, I got a little bit of pain, I don't have time, whatever. Hey, we got a massage therapist. Why don't you go see him? We got the chair in there. Let him get a 5-minute demo. Let him see how that's going to help them. Once they're on that chair, they're going to want to go for the 20 minutes. Then they're going to want to slowly break in the patient into the PT department. Funnel them through. Believe me, everybody can use a good adjustment. Right, Miss Christie? Yeah. A little louder, I didn't hear that. Okay. So obviously we know that with obese people, we have a higher BMI and all that other stuff. I'm not going to go into it. Next. Let's see. All right. Now, when you have a fat person and you have osteoarthritic joints and you have balances and checks that are different than normal in the spine, remember, every single segment actually has to move. And it's not. So now you take the 3 times the weight of the normal walking person, you'll have additional 15 pounds felt at the knees and 45 pounds felt at the hips. Why? Because it's off. So then what happens? The patient ends up in your office because they have knee pain. And when they say, I have knee pain, you look at the knee and you go, oh, I'm going to examine your lower back. And they'll say, why? I don't have low back pain. Well, you need to educate these people and tell them, you need to go see the PT department. They'll be able to explain why you need this done. Okay? Now, next. Why are you laughing, Tanya? Next. Next. I'm not going to go into that. I know. And then the next thing, what's that? What? What did he say? Okay, the next thing here is I took another study that, by the way, thanks to Google, I found all these charts. You know, it was great. Google, Wikipedia, Thesaurus. What's that other stuff? Come on, man. Come on. All right, the next thing. All right, the next thing here, we've got a group of people that they did this Australian or whatever, Norwegian, one of these studies. They took 115 patients. They divided them into 3 groups. One group was given medication like Celebrex and Vioxx and all those other, muscle relaxing and kind of treatments. The next one was given the needle treatment with acupuncture, and the third one was given the manipulation with the chiropractic. The chiropractor decided how many times for what condition the patient was supposed to be seen. Every individual was treated differently, but when you look at the early complete relief, which is in the green section in the pie chart, you'll see that there's 32%. The highest was received with the manipulation. Again, because everything is from the inside out, your body has a healing energy. It can heal itself. Believe me, it will heal itself. I can't remember how many times I've not given my kids antibiotics. I've adjusted them. I've got 3 kids. They've been adjusted, not since birth, but since 2 and on. But my youngest patient has been 18 months old. And no, I will not do an osseous adjustment. I will do the activator adjustment. It works well, okay? So just so you can see, medication 4.5, acupuncture 4.5, manipulation 32%. Again, ranking the highest proven point. Now, how do I tie all of this into ANWON? We do have a lot of obese patients in our offices. If they don't have any pain, they're lying to you. Do me a favor, nurses, assistants, or whoever it is that's seeing the patient at first hand, before the doctor walks in, you check off normal musculoskeletal, normal head, normal low back. Please be a little more in detail what you're writing in those sections, because I'll import some facts from those notes to my notes, and then I'll find all these discrepancies, and then I'll look at the other chart and say, oh, it says normal here. Now, that doesn't look right. Let's all be on the same page. Spend a little more time. As explained earlier, 85% of the population has low back pain, and the other 15 will get it somewhere down the line. Okay? Any questions so far? Good. Yes, ma'am.
One quick question. You say lower back pain is usually developed because of obesity.
One of the cases. One of the reasons.
I'm experiencing frequently now low back pain.
Okay. Have you been checked out? Because there might be a curvature change. Very commonly known curvature change may be scoliosis. And you'll find that in very skinny people, very tall people, very short people. There's no real criteria for that. All I can say is if you came to me at 14 years of age and you had back pain, the first thing I would do is check for scoliosis, because what happens is when you have a growth spurt and it turns out to be somewhere between 8 to 10 inches within a summer, there's a chance your body is not ready for that spine to just grow so fast. It'll start to bend somewhere, okay? Especially when parents are always saying, take that backpack off your back, and then, I get people who come in there complaining. I've had many 15-year-olds who've ended up with scoliosis. I take a picture, show them the scoliosis. Mother says, I told you to take that heavy backpack off. It's not their fault. They grew too fast. And no one was there to actually see and tell them, hey, you need to do these stretches, you need to do this, you need to do that to alleviate it. And it's very easily correctable at that age, because bone is so soft still at that age, 14, 15. Now, for someone your age, if you do have something like that, what we can do is make sure it doesn't go further, because the further it bends, the tighter it gets. The loss of, what happens is you have loss of motion, decreased motion, decreased motion, decreased motion, and then it turns out to be, you lose complete cartilage, and then it gets fused, and then the joint above and the joint below start working harder. Then you start developing osteoarthritis on the top and the below. Yes, ma'am. Oh, I'm almost done. Okay, great. I'm so glad at this 20-minute thing. All right, next. And how we tie it at ANWON, we've got COX-2 support. All right, we've got sub-zero for pain. And ma'am, you forgot to mention glucosamine complex. But that was with the C's, not the G's, right? Okay. All right, chondroitin. I was thinking of chondroitin, but it's got the complex. And then the Ching Wong Wong hung that you guys didn't know about, I already knew because it was for inflammation. Dr. Paul nailed it, said it was for dermatitis, but that's not what I was told. I was told for inflammation and pain and things like that. All right, so, well, anyways, those are 4 supplements we have. We got 4 supplements in ANWON that we can actually, use. And there's the ANWON director right there. We got ANWON on the screen. Look at that. 4 supplements that we can use. I tied it all up, and thank you very much. Does anybody have any questions? I hope this was